And welcome to this PrecisCa breast mini tumor board on breast cancer. My name is Dr. Reshma Matani, and I'm a breast medical oncologist and an associate professor of medicine at Sylvester Cancer Center, University of Miami, where I co-lead the breast cancer program. It's my good fortune today to be joined by several well-renowned experts in breast cancer, who I will now ask to introduce themselves. Dr. Buchholz.
Hi, my name is Tom Buchholz. I'm a radiation oncologist, professor emeritus at MD Anderson Cancer Center in Houston. I'm the medical director of Scripps MD Anderson Center in San Diego.
Terry Bauman is a breast surgical oncologist. I direct the breast cancer program at the Orlando Health Cancer Institute.
Hi, Bill Gradisher, professor of medicine and chief of HEMONC at Northwestern University in Chicago.
Hi, I'm Maxine Jockelson. I'm a breast imager at Memorial Sloan Kettering Cancer Center, professor of radiology, and I also do a little bit of PET.
30-year-old African-American woman with a history of a stage 1 ER/PR positive, HER2 negative, right invasive lobular breast cancer with definitive therapy postponed due to COVID, now with stage 4 disease with metastases to the bone. She presents recently with right hip and leg pain, but her performance status is a 0. She has no medical issues, is premenopausal, gravida 3, para 3, no hormone replacement therapy or oral contraceptive use, no hysterectomy or oophorectomy, no illicit drug use, and has a very strong family history with her mother, grandmother, and maternal aunt having been diagnosed with breast cancer in their 40s. She hasn't had genetic testing to date. In February of 2020, she was encouraged to undergo mammography at a young age due to her family history, and this study revealed a 1.6 by 1.8 by 1.7 centimeter lesion in the right breast. An ultrasound revealed a 3 millimeter lesion at 11 o'clock, 3.5 centimeters from the nipple, no lymphadenopathy. A core needle biopsy identified invasive lobular carcinoma grade 2, ER/PR positive, HER2 negative. The oncotype is 14. This is when the pandemic had just started in March of last year. And as we all went through this situation where OR time was limited or closed entirely, the patient was placed on tamoxifen and surgery was postponed due to the pandemic. And then she was lost to follow-up after losing her job and insurance. And then 6 months later, she presents with hip pain. She's still taking the tamoxifen, and the PET scan shows diffuse osseous disease, such that she has a pathologic fracture of the right femoral neck and requires surgical stabilization, and the biopsy confirms this is metastatic disease.
So we have an axial view of the pelvis on PET scan, and then a coronal view as well. And what you can see on the axial view is this destructive lesion in the right femoral neck. It's hypermetabolic, and you can see the cortex is gone. So this is a fracture due to direct erosion. And then on the coronal images, and it's hard to say for sure where all of these are on the single view, but this could potentially be in her breast by the location. Probably an axillary node here, rib metastases, spinal metastases, pelvic metastases, extensive sacral metastases. I have to admit that I would imagine, even though I would never have staged her at her presentation, she seemed to have early stage disease, but I would find it hard to believe that some of this disease wasn't present a year. I mean, this is so extensive, and it's a fairly low-grade tumor. So I have a feeling she had de novo metastatic disease at presentation.
I was thinking the same thing. As you know, we had frequently offered patients at the start of the pandemic this type of approach. The feeling was that it was certainly reasonable to go that route in an ER positive, HER2 negative tumor. And the timing of this is such that it makes you a bit suspicious that perhaps this was there right from the beginning. Dr. Gradisher, I'll just ask you, with COVID aside, I'd like to start by discussing how you would have managed her if the pandemic hadn't been a factor. She had an oncotype of 14. She's premenopausal, and has a node negative tumor. Of course, hindsight's 2020. We know she developed metastatic disease, but would you have offered this patient chemotherapy if she had been able to undergo primary surgery up front and not had that delayed?
I think it would have been a consideration, or optimizing, her endocrine therapy with ovarian suppression added to endocrine therapy. Of course, that's water under the bridge, and this is a very unfortunate scenario now.
She has diffuse disease as described in the bone on PET, but I'm wondering, Dr. Buchholz, if her presentation was such that she had maybe one or just a handful of lesions in the bone, would you have any enthusiasm to offering her radiation to those areas with limited bone involvement?
Yeah, the situation you're describing is sometimes called oligometastases. And there is increasing evidence from clinical trials that ablative treatments of the metastases, in addition to optimal systemic treatments, may have a positive impact on the disease course. So there has been a trial that was a randomized trial specifically in breast cancer that we don't have the data yet back on, but other trials such as the SABRE trial, which included many different histologies, have shown an improvement in outcome with ablative treatments. Now, some of those treatments can be surgical. Other times we use highly conformal high dose per fraction called stereotactic body radiation treatments, which can easily target bones or liver lesions or lung lesions. Again, we can use stereotactic treatments in the intracranial metastases as well. So we are finding that where we once considered just using radiation, say after a hip fracture for palliation, now we're taking a different approach and being much more aggressive with these truly higher dose ablative treatments of isolated metastases. Unfortunately, for someone like this, where they have metastatic disease throughout a lot of their skeletal system, it's unlikely that radiation is going to be of benefit beyond the palliative historical use.
I just want to point out that the coronal view is backwards. That this is her liver and this is her right breast cancer. Just to be accurate here, doesn't
Thanks so
really
much.
change anything. Did she have a biopsy of her metastases? Any of her metastases, and they were the same pathology?
Yeah, I was going to raise the same concern. We don't have that information that suggests that she had a biopsy, but that would certainly be important to do to confirm the diagnosis and to recheck the markers. Dr. Gradishar, I'll ask you that, she's young and she's developed metastatic disease while on tamoxifen. Presumably this may have been there at presentation, as we discussed earlier, but say it wasn't, and she actually did in 6 months develop this amount of bone disease while on tamoxifen. Would you consider this primary endocrine resistance and move straight to chemo, or would you be comfortable using a CDK4/6 inhibitor in combination with hormonal therapy in this young patient?
Yeah, so in this young patient with diffuse bony mets, but no real visceral disease, that pattern is still pretty consistent with ER-positive disease. And of course, I would concur that I would probably get a biopsy to ensure the markers and, make sure she doesn't have an estrogen receptor mutation, something that's evolved on endocrine therapy. But all that said, I would probably, as a first step, still revert to a CD4/6 inhibitor and ovarian suppression plus an aromatase inhibitor. And we have data from the MONALESSA 7 trial that showed that there was actually a survival benefit in patients who received that therapy. So I don't see the need from anything that's clinically going on that you have to have an immediate instantaneous response that would justify the toxicity of chemotherapy, which will be in her future at some point, but there's no real role right now. And I would also, I'm sure she's going to get genetic testing, and we would want to make sure that she didn't have a mutation, because at some point, even if it were positive now, I'd still give her endocrine therapy. But if she had a mutation, a PARP inhibitor may be in her future as well.
Right, and then the last recommendation, of course, for a bone-directed therapy to decrease the risk of skeletal-related events. So in summary, the panel concludes that we would recommend a biopsy to confirm the diagnosis of metastatic breast cancer and confirm the markers, would recommend the use of a CDK4/6 inhibitor and hormonal therapy and ovarian suppression, genetic testing, certainly with her family and personal history of breast cancer, and bone-directed therapy to decrease the incidence of skeletal-related events. So with that, I thank you all for your valuable insights into all of these cases. Thank you.